morning once again, students. Today we're coming to talk about the third nerve and its palsy. So when it has a problem in the eye, the manifestations. So talk about the third nerve palsy or paralysis. Before we start, let us remember the structures that the third nerve innervates within the eyeball and around the eyeball. Remember, it has an upper part and a bigger lower part. An upper part and a bigger lower part. Okay, the upper part innervates the levator pupillary superioris, whose function it is to help in elevation of the upper lid. It also innervates the superior rectus muscle, which helps in elevating the eyeball itself. Again, we should remember that the inferior part innervates more structures. Notable amongst them are the medial rectus, which helps to pull the eyeball inwards. It innervates also the inferior rectus, which pulls the eyeball downwards. It also innervates the inferior oblique muscle that when it contracts, it sends the eyeball upwards and inwards. Again, it has sympathetic fibers. Okay, it has pupillomotor parasympathetic fibers that serve the pupil. To be more specific, there are two muscles within the pupil, the constrictor pupillae muscle and the dilator pupillae muscle. But it serves the constrictor pupillae muscle. Alright? Of course, we talk about also another muscle which itself is what? The ciliary muscle of accommodation. Ciliary muscle of accommodation. So today, let us talk about the features of third cranial nerve palsy. In our previous class, we talked about ocular muscles. If you revise the lesson on ocular muscles before you come and learn on the third nerve palsy, it will set as a stepstone for better understanding of the third cranial nerve palsy and its manifestations. So, look at these two eyes. This is the right eye and that is the left eye. In our previous lectures, which consisted of eyelid normal position, we said that the upper eyelid lies at the level of the limbus. In young people or in older people, it may be found lying at the level, lying 1.5 to 2 millimeters below the inferior limbus. That's the normal position. So let us compare these two eyelids. You realize that the right eyelid has drooped further down. Okay. Generally, when there is third cranial nerve palsy, the affected eyeball is down and out. In majority of the cases, the affected eyeball is what? Down and out. Down and out. Majority of the cases. Let's look at this particular picture. The eyeball is down and out. It's not only depressed downwards, but it's gone outward. That's the right eye. Look at a second picture. The eyeball is down and out. It's not only depressed downwards, but it's gone out. Let's look at the third picture. The eyeball is depressed downwards and it's gone out. Now let's look at something else. In all the three cases, the affected side is the right eye. Please don't get wrong impression that third nerve is more common in the right than the left eye. Don't also think that because of my presentation, third nerve pulses don't occur in the left eye. No, that is not true. You should remember that it can happen in any eye. It is just coincidental that the three pictures that I'm using to demonstrate to you are all at the right side. So let's go down to nitty-gritties. So students, if the third nerve supplies the levator pulpare superioris and then it is weakened, do you think that the levator can function properly by opening the eyelid? The answer is no. That is why. So there are two major muscles. One is the levator, and we also have the orbicularis oculi muscle. Remember? Okay. So the antagonists for the levator pulpare superioris is what? The orbicularis. So once the levator cannot help in elevating the eyeball, okay, then the orbicularis takes over. That is why the eyelid droops. It's closed because the third cranial nerve palsy. So that's number one. Number two, why is the eyeball drifted outward laterally? Okay, it is simple. Remember that the medial rectus muscle is served by the third cranial nerve and there's a palsy. Its antagonist, the antagonist of the medial rectus is what? The lateral rectus muscle. So therefore, if the medial rectus is weak, the lateral rectus takes over and drifts the eyeball outward. Very simple. Okay. Now, let's talk about why the eyeball has depressed downwards. Remember that for the eyeball to come downwards, let's remember few things. Okay. And it's a gameplay between superior rectus, inferior rectus, superior oblique, and inferior oblique. I repeat, it's a game played amongst these particular muscles: superior rectus, inferior rectus, superior oblique, and inferior oblique muscles. Okay, let me start with the superior rectus muscle. The question is the superior rectus muscle affected in third nerve palsy? Yes, the answer is yes. Okay, it means that it cannot pull the eyeball upwards. Alright? Alright. Is the inferior, so if it cannot pull the eyeball outward, upwards, it means the eyeball most likely will be found downwards. Okay, but it doesn't end there. Step by step. The inferior rectus muscle will have a problem with the third neck cranial nerve palsy? Yes. So it cannot pull the eyeball downwards. Okay, so most likely the eyeball will be up. So both the superior rectus and inferior rectus muscles are what? Affected. In that case, we expect the eyeball to be at the midline, neither superiorly placed nor inferiorly placed, so at the midline. Okay, now let's talk about the obliques. So if it left the superior rectus and inferior rectus, the eyeball is midline. It's neither drifted upward nor downwards. But here you find it downwards. Okay, so explanation one by one. Second group of muscle we need to analyze are the obliques. Okay, all right. What does the inferior oblique muscle do? The inferior oblique muscle ideally needs to send the eyeball upward and then inward. If the inferior oblique muscle is affected, can it send the eyeball upward? No, it can't send the eyeball upward and inward. So, the eyeball, the antagonist for the inferior oblique muscle is the superior oblique. So to start with, because the inferior oblique has a palsy, alright, because the inferior oblique has a palsy, it can't send the eyeball upward. So, the eyeball may be found downwards. The antagonist for the inferior oblique muscle is what? The superior oblique muscle. Is the superior oblique muscle affected in third nerve palsy? No, because it is innervated by the trochlea or the fourth cranial nerve. Is it affected in third cranial nerve? No, because the trochlear nerve is not affected. And what is the function of the superior oblique muscle? The function of the superior oblique muscle is to pull the eyeball downwards and inwards. So once the inferior oblique muscle is weak, its antagonist, which is the superior oblique muscle, takes over to bring the eyeball downward. The superior oblique muscle takes over to bring the eyeball downward. Ideally, it has to bring it downward and inward. But for the eyeball to move medially, it needs the help of medial rectus, but it's also paralyzed. So therefore, it is taken or drifted outward by the lateral rectus, which is still strong. So I repeat, let me repeat what happens between the inferior oblique and superior oblique. The inferior oblique muscle has a palsy. It cannot send the eyeball upward and inward. So therefore, the eyeball most likely will remain what? Downward and outward. That's number one. Number two, the antagonist for the inferior oblique muscle is what? Superior oblique muscle. So if the inferior oblique muscle, there's a pulse, it means that superior oblique muscle will take over. Interestingly, superior oblique muscle is not innervated by the third cranial nerve, for it is innervated by the fourth cranial nerve, which is known as the trochlear nerve. And what does it do? It supplies the trochlear nerve, it supplies the superior oblique muscle, and the superior oblique muscle brings the eyeball downwards. Interestingly, the superior oblique muscle brings the eyeball downwards and inwards. Yes, it has taken over, so to bring the eyeball downwards, but it couldn't bring it inwards. Why? Because the medial rectus muscle has a problem. It can't pull the eyeball medially, so the lateral rectus, which is still strong, pulls the eyeball laterally. So it's an interplay between inferior oblique, it cannot send the eyeball upward and inward, so eyeball is drifted downwards and outward. Superior oblique muscle, it can only send the eyeball downwards. It's not innervated by the third cranial nerve, so it is still functional. Okay, so send the eyeball downwards, but I can't send it inwards because the medial rectus has paralyzed. So the lateral rectus takes over. That is why the eyeball usually found downwards and what? Outward. Okay, one big question here is, why therefore is the pupil dilated? Remember that in all third cranial nerve pulses, you may not find the pupil being dilated. But in those scenarios in which it is dilated, let's give explanation as to why. Okay, remember that when the third cranial nerve courses through the brain or passes through the brain, okay, the parasympathetic pupillomotor fibers that are found around the nerve are superficially found. Okay, the parasympathetic pupillomotor fibers are located at the superior aspect of the nerve. So therefore, when there's any compression on it, it can be from tumor, it can be from bleeding into the brain, it can be from trauma. So because the pupillomotor parasympathetic fibers for the Westphal nucleus, remember the ocular muscle lecture, revise it. So the parasympathetic pupillomotor fibers that help to innervate the constrictor pupillary muscle are affected because they are more superficial. So when there's trauma, intracranial bleed, anything that compresses it, even raise intracranial pressure, okay, trauma, all these factors, all right, can compress the superficially placed parasympathetic pupillomotor fibers. Once they are compressed, now the constrictor pupillary muscle cannot constrict. In that case, it's an antagonist. The dilator pupillary muscle takes over and the pupil becomes what? Dilated. That is as simple as that. Okay, that is as simple as that. So in this particular case, the pupil is dilated. In this case, it is not clear, the right eye. Okay, it is not clear at all. But in this case, it is also clear the pupil in this eye is dilated. Okay, let us talk about etiology or causes of third cranial nerve palsies. Okay, what can cause third cranial nerve palsy or oculomotor nerve palsy? Okay, but there's something I should also have told you when I was talking about the manifestations. Remember, the lateral rectus is not affected, and the medial rectus is affected. So the antagonist of medial rectus is what? Lateral rectus. So now that the medial rectus cannot pull the eyeball medially, the lateral rectus takes over. That's why it is out. And I've explained to you already how it moves downwards. So classically, third nerve palsy's etiology is classified into surgical and non-surgical causes. I repeat, surgical and non-surgical causes. The surgical ones are also known as people involving third nerve palsy, and the non-surgical ones are also called pupil sparing third nerve palsy. Why do we say that the people involving ones are surgical in nature? They are surgical in nature because almost all of them, they will need surgical intervention as solution to the problem. If there's something compressing on the pupillomotor parasympathetic fibers, until we release that particular compression, the pupil size will not change. The third cranial nerve palsy will persist. That's why we say it's what? Surgical. If it's intracranial pressure, it has to be reduced. If it's intracranial bleed, it has to be evacuated. Okay, to bare whole craniotomy. If it's intracranial tumor, until it is taken away, this compression will not be released and the third nerve palsy will what? Persist. So that is why we say that the pupillary involving ones are surgical in nature. Okay, so the pupil sparing third nerve palsies. Pupil sparing third nerve palsy. Let's assume that this pupil is not dilated. Okay, the pupil sparing third nerve palsy. What are the etiologies? Okay, basically they might be caused by vascular problems. Vascular problem. What do I mean by vascular problems? I mean diabetes, hypertension, hypercholesterolemia, and sometimes there's a third major etiology, which is what? Unknown, 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 and unknown. So, I repeat, the vascular causes: diabetes, hypertension, hypercholesterolemia, and there's a third major etiology, which is what? Unknown. The cause is just unknown. Okay, so why is it that these vascular causes don't cause dilatation of the pupil? The answer is simple. Number one, they don't cause compression of pupillomotor parasympathetic fibers. Number two, diabetes, hypertension, hypercholesterolemia. With our knowledge in medicine, they cause what we call microangiopathies. Microangiopathies. Which vessels do they affect? Okay, so the trajectory or that part of the third nerve which passes through the brain has its own nutrition from blood vessel, and this blood vessel is known as what? The vasa nervorum. Vasa nervorum, a vessel part of which is found within the nerve to serve and give it nutrition. Vasa nervorum. It is found at the inner portion of the nerve. So any external compression from the brain to raise intracranial pressure, tumors, intracranial bleeding, direct trauma will not affect the vasa nervorum per se, but it will affect but diabetes, hypertension, hypercholesterolemia, if not properly controlled, yes, have the capacity to affect the vasa nervorum, which is found at the inner portion of the third cranial nerve. So external compression will not, but because there is slow progressive microangiopathy from diabetes, hypertension, hypercholesterolemia, these can affect the vasa nervorum and then cause third nerve palsy. But it does not affect the pupillomotor superficially placed parasympathetic fibers. That is why in the case of the vascular causes, you don't usually see people being dilated. Let me also add that when we shine light into somebody's pupil in the normal circumstances, what is the normal response? There's reconstruction of the pupil. So, at the initial stages of surgical third nerve palsy, in which case the pupil is dilated, it takes time for the constrictor pupillary muscle to be paralyzed and for the dilator to take over. So, at the initial stages, few hours to days, and even sometimes to weeks before the pupil becomes dilated, the pupil will not constrict to light. So there are two ways of diagnosing the surgical third nerve palsy and its etiology. One way, and which is will be very obvious, is the pupil being dilated. And of course, the other features of third cranial nerve palsy. The other way is that when you shine light into the pupil, in this case, the pupil will be normal size because it hasn't gone to get the normal hours and days that it needs to affect the parasympathetic pupillomotor fibers. So the pupil will still have normal size, but once you shine light into it, it will not constrict. It will not constrict at all. So if there are other manifestations of the third cranial nerve, like the late, there is blepharoptosis, the eyelid, the eyeball is drifted downwards and outward. If these other manifestations are there, people is not dilated. But once you shine light to the undilated people, if it does not react, if it does not constrict, it means that yes, we also call that one people involving. So you don't only need dilated people before you diagnose people involving or surgical third nerve palsy, because sometimes the people is normal size. So what is the take home here? That before you talk about surgical third nerve palsy or people involving third nerve palsy, you need to do what? You need to shine light into the people, okay? And once it constricts, then people is paired and you go to the vascular causes. But if the pupil stays the same size or it even dilates to your light, then it means that the pupil is what? Involved. And if the pupil is involved, then you narrow down your diagnostic features to the uh, people involving ones. Okay? Alright. So if you have a client who comes to you and you realize that the person has third nerve palsy, remember that diseases like diabetes that are also we say that they belong to the people sparing ones, but very long standing diabetics also have their pupillomotor fibers affected, so therefore the people might be what? Affected. Yet the general rule you should establish for yourself is that people involving ones means that once you shine light into the people stays the same, it does not constrict or it even dilates. Okay. Or sometimes you don't need to shine light. You realize that apparently one people is what dilated. Then you're talking about what people involving. Then talk about what the surgical cause. Or non-people involving ones. Then talk about what the vascular cause. So once a patient comes to you with third nerve pulse, there are few take home that you need to do. Number one, check blood pressure. Ask the patient to do fasting lipid profile and of course do fasting blood sugar. Take good history. Ask about trauma. Okay, and so on and so forth. So, in which case do you want to ask for CT scan of brain when a patient comes to you with third nerve palsy? Of course, it is the people involving one. It's the surgical ones. You want to know what is happening in the brain. That's why you go asking for either MRI or CT scan. But if the people is paired, ladies and gentlemen, don't waste the patient's money by asking him or her to go and do CT scan or MRI of the brain. So this is what you should know about so far as the third cranial nerve palsy is concerned. Look at this particular picture. The examiner needed to even lift the eyelid because of the fructose from third cranial nerve before he could see the ocular features. Students, I want to end my class here and urge you on to continue reading, look at the YouTube, listen, watch it, and if there are any difficulties, approach me in class so that I can clarify your doubts and your difficulties. Until we meet again, continue learning and take good care of yourselves. This brings me to the end of my lecture.